Excellent. Get myself all situated here. Thank you very much. So yes, my name is Casey Sharpe, and I'm here on behalf of the Safe Inhalation Pipe Provision team, i.e. SIPP. And so what I'm going to do today is talk through a little bit of scene setting for the intervention, describe the intervention itself, and then some of our preliminary findings from our baseline survey and some of the qualitative results we've got, with a few minutes at the end for some questions. So, something that will surprise probably no one in here, stimulant use is common and increasing in the UK. Looking at the crack numbers or prevalence estimates from OHID, we see an increase in about 20% between 2016-17 and 2019-20. People are using stimulants. Don't need to spend too much time there. And yet, if they want to receive any supports, there's very few available for them, especially people that smoke. One such example is there's no pharmacotherapy options licensed for stimulant dependency. So unlike people using heroin and opioids, they don't have an OST. So if they're going through mental withdrawals, there's nothing there to pharmacologically help them with that. And a little bit of a jumping forward, a lot of our interviews with staff and people that use crack really emphasize just kind of this desert of provision which is available for this group. And then at the same time, from a harm reduction perspective, stimulant smoking equipment provision is prohibited under UK law. So we have the Misuse of Drugs Act here, and we're talking specifically about Section 9A, and that is by exemption. So basically, if you're not on the list, you're not able to distribute those equipment legally from services. So Claire had mentioned earlier foil. Foil's on that list, as is injecting equipment, but any type of other smoking equipment isn't there, so services are liable to prosecution if they distribute it. So if you don't really have any supports available for people using crack and other stimulants, and there's not really any equipment they can pick up, what's the reason to come into services or disclose their use? It's a question. And that's kind of within the context of why we came out with this study. And the aim of the study was to evaluate a safe crack inhalation intervention distributed to people using crack, distributed by drug treatment services, outreach, and peers, with the intent to reduce crack-related health harm and inform legislative review. And the intervention itself had three components. One was the actual SIPP kit and all the equipment itself, which I'll show you on a later slide. And one was a provider e-learning training. And this gave kind of the basics about crack use and harm reduction, as well as a peer-to-peer component. And actual distribution of the kits ran for a 6-month period from summer of last year to February of this year. And this was done in 3 intervention sites, as well as 3 control. And how we've evaluated it was a mixed methods approach. So we had a survey with people that use crack, both in and not in contact with services, asking some questions around demographics, drug use practices, harms, that kind of thing. And this is the punchy impact evaluation, your quant, your numbers, that kind of thing. But then we've also done a qualitative analysis and looking at monitoring data. So looking at the process of what actually got implemented, what was acceptable to people, what was feasible, those type of questions. And then also the brass tacks of economic evaluation, something that I'm sure everyone here is probably interested in. And that's in the works right now. And if you'll remember from the previous slide, it is currently illegal to distribute pipes. So what we had to do was get a local letter of comfort from the police forces that were involved with our intervention sites. And that's just in a sample letter, as you can see up there on the screen. Okay, and what were we hoping to get? So primary outcome was a reduction in shared crack pipe use, but kind of everything you see on the screen there we're interested in. It's increasing that engagement and contact with services. It's a reduction in the use of homemade pipes and filter devices which aren't great for you, such as ash, and acute injuries related to that. But if we're talking in this, making every contact count type of context, we've got stuff like Hep C prevention, reducing respiratory risk, and whatever else people may need assistance with if you're coming into services. And then there's the actual components of the intervention. So up in the top laser, that is the e-training for our staff, as well as the actual kit itself contained 1 straight stem pipe, 2 gauze or filters, 2 mouthpieces, a wooden push stick for collecting your recycle, and then some handy dandy information leaflets. So that is the intervention itself. And so now I'm actually going to get into some of the results that we found. So here we are in the process of analyzing the after implementation survey. So this is all based off of the pre, but it's going to give us a little bit of insight as to who this population is. And as a reminder, the eligibility is people 18 plus who are using crack, and it can be injecting or smoking, in touch or not in touch with services. So a whole bunch of information up on that board there, but some things maybe just to alert you to is people were using crack for an average of just over 2 decades, but it was a range. You had people just starting that year up to 50 plus years, as well as multi-substance use with those listed above, but just under half were also either unstably housed or rough sleeping. And thinking about the fact that we don't really have a lot of services, particularly for people smoking stimulants, we have, there we are, 2/3 of our cohort did not inject drugs in the past month, and about 2/5 are not on OST. So just something to consider there. And then we asked them, what are some potential harms you experience from crack use? Maybe not surprisingly, there's a whole bunch that people experienced. About 5 and 6 had some type of harms, and those related to acute, so cuts and burns and things like that related to the actual equipment that was getting used, as well as respiratory and mental health. And we asked a variety of questions. Some were about diagnoses you had, some were about hospitalizations, and for anyone who's really quick at reading numbers and analyzing things, you might see there's a bit of a gender disparity up on the screen there, particularly for respiratory, and we're not sure exactly why this is. So be really curious if anyone has any ideas at the end of this to come and chat. Okay, diving a little bit deeper into what types of pipes are people using in a context of not having access to safer pipes through services, and what are those associated risks. So common devices, you can repurpose your store-bought metal pipes and your glass pipes, or we also have people who are making their own homemade ones out of what they have available. So spirit bottles, inhalers, tin cans, and then for the actual filter material, you have brass gauzes, ash, cigarettes, fairly common, as well as steel scrubber or wire wool, stuff you're using for cleaning your pots and pans. And each one of these has their own specific risks associated with them. So inhalers, for example, you run the risk of, if you are scraping your pipe, you can be shaving off some of the plastic bits, and then those get heated and you inhale those toxic fumes. As well as if you have the short little store-bought ones or metal ones, they can get really hot. So firstly, you're potentially going to burn your fingers, your mouth, all that kind of stuff. But then because they're hot and it's hot air in a very short, narrow space, blast hot air into the back of your lungs and causing issues there. And then when you actually look at the suspension devices and the filters, you have ash and people reporting coughing up black gunk. And then for the stainless steel scrubber, especially if people don't change it very often, the steel can get quite brittle, and you can have little bits break off and get very hot, and again, back of your throat, fingers, really unpleasant. So what are some of the implications here for health harms? With pipe scarcity, with not being able to distribute them via services, you run the risk of increasing pipe sharing, of which it was common among our cohort to share pipes. A whole bunch of reasons go into that, but potentially pipe scarcity is one of them, with someone here talking about an example of a cold sore, whipping around a group because they're using the same pipe. And then from having these homemade pipes and the issues I was talking about before, people experience really sometimes debilitating respiratory harms from this, and it's too negative on their life to keep smoking it, so instead they transition towards injecting. And one thing which has been touched on already is mental health need, huge levels of unmet mental health need in this group, and it's hard to get the mental health support due to their current drug use, yet we know, I can see what everyone is talking about here for hitting that thing. Hand in glove, it's cause effect bidirectional, and then when people are maybe trying to reduce or stop their crack use, the mental withdrawals that go with that are horrendous. And we found in our cohort that over 60% needed some type of mental health support, and of that group, over half were not able to get any. And a really common story that we had heard from staff, from people that use crack, is the barrier to getting that support is the fact they're using substances. So you get stuck in this catch-22, and yeah, it's a very, very common narrative. Okay, and then talking about SIPP itself, I'm sure you're all curious. Anyway, so what we did when distribution was happening is providers would fill out a short little monitoring survey every time they distributed some equipment and giving us some basic information. And of the about 3,400 kits that were distributed, we found 205 people. It was their first time going into any drug treatment services ever, and the vast majority, 177 of those, came in because of the pipes. But that's a pretty huge undersell, because when you actually talk to people, that's a really blunt measure. Have you ever been to any treatment service ever? And instead, with staff, they're like, this might be someone who hasn't rocked up for 5 years, or they've never been to our service, but they've been somewhere else. So when you actually talk to them, those 50 new contacts, in practical terms, are actually closer to 300 for that particular example. And so you have new people rocking up, but it's about more than that. It's about what happens when someone is there in front of you. And we heard a number of stories about, people rocking up and having all of these other unmet needs, having conditions that have been undiagnosed or untreated for ages. And SIPP, drawing them in, allowed the staff the opportunity to follow up. So doing things like getting sexual health testing, BBV testing, GP appointments, that kind of thing. But it's also not just new people. There's people in services who might be there for script, might be there for alcohol treatment, and it was through the SIPP intervention that they had disclosed their use and asked for a pipe. And through these, with the new people, with the current people, staff were having more conversations, and it was more bi-directional learning between the two. So there's a sample quote there, someone who said, we probably had this person come in 60 times a year to our needle exchange, probably had their pipe in their pocket the whole time, and it was only because of this intervention that we had this dialogue. But going to the importance of training, we also think it was partially to do with the training, because we heard from a lot of people that a lot of their training previously had focused on injecting, on opioids, and people didn't feel that they had the base level knowledge to be comfortable to engage in these conversations, and some of that training helped give them that base level of confidence. And it gives the opportunity to potentially build trust with people over time. And I think Claire had mentioned earlier something about workforce. So one of the things too, whether it's workforce, institutional legacy, or funding, engagement's also a two-way street. So there were some examples where someone would come in for a pipe, they would be handed a pipe, and that's where the conversation ended. So there's still work to be done on kind of that engagement front as well. And the feedback on the kit wasn't all sunshine and rainbows. We did get some critiques in design, and so original pipe length, too long. So instead, we came back and spoke with the Exchange Supplies and introduced shorter pipes. The gauze was also too dense, as you can tell there. It's pretty well packed in, and people felt it negatively impacted the high, would get quite gunky, and so one of the staff figured out a way to unravel it, which we tried to show people. But again, also speaking to the manufacturer, are there ways we can get less dense gauze to start? People didn't really like the cases and the push sticks, so the result of that is you get broken pipes because they're just kicking around in someone's bag. But overall, there was huge support for the intervention itself, for the concept of providing that type of equipment, and just considering the groups and the needs of this group. And also that we had listened and acted on that feedback. So when they said they didn't like the pipes, we gave you a pipe based off of your needs. So that's been really wonderful. And summary final points. Oh, we're going to do this. Okay, so we are the first UK site to pilot this. This is an intervention which has happened in other countries, but we're creating an evidence base for our local populations and about this population which has existed for decades but hidden to services and researchers about their drug using practices and their health needs. So that's something that's been really wonderful about it, as well as the engagement, reminiscent of the foil examples, with the potential to reduce respiratory risks and BBV, and considering the implication of nitazines. I heard, Robin had mentioned some potential concerns about that, but this is about, more tools in the toolkit and risk levels. And then as of right now, we're doing that analysis of the follow-up survey. And so preliminarily, some positive outcomes related to, reductions in sharing and injecting and things like that. So that's a to-watch space. But really importantly, we need to consider how to improve reach. I know Wes talked earlier about peers and distribution, and there's a whole bunch of reasons people may not feel comfortable coming into services. So that's something to consider, as well as I think Adam's point about making more inclusive services, because we didn't get into it on that demo survey, but a lot of white men that were in that group, which is great, they need support, but there are other people that also need access to these really important pieces of equipment. And it is being rolled out at this point in certain local areas. But what we do really need is legislative change, because we want to avoid a postcode lottery. It shouldn't really matter where you live. You should be able to access these type of services. And pipe provision is really only that first step. You know, we need other things like pharmacotherapy. We need supports for people, as well as mental health supports, which I know Katie had mentioned there, and the difficulty in accessing it. So that's the whirlwind. Thank you for having us here. Thank you to everyone on that board. And if you want more details, here's all the info, and then also ask me. Feel free.